So good morning, everyone. So again, a new Monday has come with new knowledge, and today we will discuss only morphine. Those who are attending these classes since the last 2 years, they are using morphine every day almost, and they are the maximum. They are the maximum user of morphine. And what exactly we should do, we will discuss this. And before we start discussing, I request Dr. Jayata to introduce Dr. Bhagat and Dr. Prasun because they both are from Tata Memorial team and no one can introduce better than Jayata. So Jayata, I request you to introduce both Dr. Bhagat and Dr. Prasun.
Hello, good morning, ma'am. Good morning, everyone. It is my pleasure to introduce Dr. Prajakta Bhagat, who is going to do this presentation on morphine today. So Dr. Prajakta is our MD Palliative Medicine student in her 3rd year now and will be exam going soon. As you can see from this, she really has a great interest in gynecological malignancies. And she's also interested in palliative care in respiratory disorders and also pediatric palliative care. Prajakta, what we all really admire her is her determination and her dedication to do her work. And she has been working very hard to do this presentation today. Thank you, Prajakta. We have Dr. Prasun today to moderate the session, and Dr. Prasun is our senior resident, currently doing his bond senior residency in Department of Palliative Medicine. He got his palliative medicine degree in 2021, where he got a distinction. He also has various others honors, like recipient of the late Dr. Narayan Bisaria Gold Medal in Medicine in his MBBS and then in surgery, and other gold medals in pharmacology and pediatrics. As you can see, he's a member of different international collaboratives in Australia, and he is a member of MASC. And he has been the member in the PACCSE Cardiovascular Disease and Stroke Research Hub. As I have told you before, Dr. Prasun is the epitome of evidence-based medicine, and his work is mainly translating evidence into clinical practice, and he has also taken part in the Accord Protocol Development Workshop. So thank you, Dr. Prasun, for moderating this session. Over to you, over to Prajakta and Prasun.
Thank you for the generous introduction. Prajakta, are you ready? You're muted.
You can start sharing slides, Prajakta.
Yeah.
Yes, we can see the slides. Go ahead.
Good morning, all. And thank you, Jayata ma'am and IAPC for giving me this opportunity. So today's topic is morphine. It is a prototypic opioid antagonist and has long been known to relieve acute severe pain with remarkable efficacy. The opium poppy is the source of crude opium from which Sertner in 1803 isolated morphine, the pure alkaloid, naming it after Morpheus, the Greek god of dreams, and it remains the standard against which all drugs that have strong analgesic actions are compared. It is a strong opioid analgesic belonging to phenanthrene class, and it is a phenanthrene alkaloid and consists of 5 condensed rings, the C3 phenolic and the C6 secondary alcoholic group together with the amino group make the otherwise structurally rigid morphine molecule chemically active. And morphine is a weak base with an associated acid dissociation constant of 7.9. And at the physiological pH, 76% of the molecules are ionized. And because of the 2 hydraulic OH groups present at the C3 and C6, morphine is relatively water soluble and poorly lipid soluble. So before understanding the mechanism, I would first like to discuss a opioid receptor in short. So in nervous tissue, opioid peptides function as neurotransmitters. They are synthesized as large inactive precursors in the neural cell body and are then cleaved while being transported to the nerve terminals. The active fragment is released into the synapse and binds to one or more receptors. So four main opioid receptors, mu, kappa, delta, and opioid receptor like 1, distributed in varying densities throughout the body, particularly in nervous tissues. So their natural occurring ligands are opioid peptides, and together they contribute to various physiological functions, including the modulation of pain, hormone, and immune system. So they are found both pre and post synaptically, with the former predominating, controlling the release of several neurotransmitters, and they produce analgesia primarily by interacting with mu opioid receptors in the CNS, example in the dorsal horn of the spinal cord and periapical gray area of the midbrain. And they are synthesized in the dorsal root ganglia and transmitted to peripheral as well as central nerve terminals. And in the presence of tissue injury and inflammation, the number of peripheral opioid receptors increases, and exogenous and endogenous opioids released by the activated inflammatory cells in close proximity to nerve fibers thereby exert a peripheral analgesic action. So all opioid analgesics act as agonists at the mu opioid receptor. Coming to the pharmacology, the routes of administration are as following: oral, intravenous, subcutaneous, intramuscular, intrathecal, epidural, rectal, and topical. So it is absorbed well when given by subcutaneous and oral routes. And after oral administration, it is absorbed in the upper intestine in the mucosa of the rectum. And the most rapid absorption takes place in the alkaline medium of jejunum and duodenum, where morphine is mainly unionized. And the bioavailability per oral is around 35%, ranging from 15 to 64% and 25% per rectally. And the peak effect is less than 60 minutes per orally, 20 minutes IV, and 30 to 60 minutes intramuscularly, while 50 to 90 minutes subcutaneously. And time to peak plasma concentration for per oral is 15 to 60 minutes, and 10 to 20 minutes intramuscularly, 15 minutes subcutaneously, and 45 to 60 minutes per rectally. And plasma half-life for per oral is ranged from 1.5 to 4.5 hours and 1.5 hours IV. And duration of action is around 3 to 6 hours. The buccal morphine, it is slowly absorbed through the buccal mucosa, but majority is swallowed. And the rectal morphine, from the lower and the middle rectum, it will enter the systemic circulation, bypassing the liver. And from the upper rectum, it will undergo hepatic first pass metabolism after it enters the portal circulation. And 25% of it is absorbed. In spinal morphine, it is generally combined with the local anesthetic, bupivacaine, and sometimes with clonidine. And topical morphine, painful skin ulcers, pressure sores. The formulation is 1 milligram per 1 ml, that is 0.1% gel preparations. And higher concentrations like 0.3 to 0.5% are used in inflammatory pain of vesicovaginal fistula, rectal ulcerations, and also topical mouthwashes in combination with lignocaine and diphenhydramine. And nebulous morphine is used in patients with intractable dyspnea. Coming to the metabolism, the principal site of metabolism is liver, intestine, and other sites such as CNS via glucuronidation. So phase 2 metabolism through uridine diphosphate glucuronylyl transferase. So the major metabolic pathway, and it results into two major metabolites, morphine 3 glucuronide and morphine 6 glucuronide. Morphine 3 glucuronide it has no analgesic effects, and it has neuroexcitatory effects such as allodynia, myoclonus, and seizures, and it cannot cross blood-brain barrier. Whereas morphine 6 glucuronide, which is an active metabolite, potent analgesic properties, and can cross blood-brain barrier. It is also metabolized by CYP3A4, which is a minor and produces minor metabolites like normomorphin, which is inactive, and hydromorphin, which is an active metabolite. Coming to the pharmacodynamics. Once the morphine binds to the receptor, conformational changes occur, allowing interactions with 3G protein, which subsequently dissociates into its various subunits responsible for multiple downstream effects. So the primary efferent neurons originate in the periphery and carries pain signals to the dorsal horn, which is not shown in the figure, where it synapses via glutamate and neuropeptide neurons, which are transmitted with the secondary neuron. And pain stimuli can be attenuated in the periphery under inflammatory conditions by opioids acting at mu opioid receptor, or blocked in the efferent axons by local anesthetics. The action potential reaching the dorsal horn can be attenuated at the presynaptic ending by opioids and calcium channel blockers by alpha-2 agonists, and possibly by drug that increases synaptic concentration of norepinephrine by blocking reuptake. Opioids also inhibit the postsynaptic neurons, as do certain neuropeptide antagonists acting at norepinephrine 1 and other neuropeptide receptors. So in opioid analgesia, the G protein is inhibitory and its subunits close calcium and other ion channels, open rectify potassium channels, and reduce recyclic adenosine monophosphate production, thereby reducing neurotransmitter release and nerve impulse transmission. So several kinases cascades are also activated. Example, signal regulated kinases, C-junction and terminal kinases, and AKT protein kinase B, which have a wide impact on cell function. Example, through changes in protein expression, receptor activation. Conversely, some G proteins have stimulatory pro-nociceptive effects, which may play a role in opioid-induced hyperalgesia. So here we can see the GI and GO subunits. So alpha and beta gamma units. The beta gamma units, it increases the potassium conductance and causes membrane hyperpolarization, thereby suppressing the depolarization. It also reduces calcium channel activity, thereby decreasing the release of neurotransmitters. And alpha unit, it decreases activity of adenyl cyclase, thereby reducing cellular cyclic AMP and decreasing protein kinase A activations. So following agonist binding and G protein activation, the morphine receptor is phosphorylated, enhancing the binding of protein B at arrestin 2. This prevents G protein coupling and facilitates receptor internalization for recycling or destruction, and desensitizing the receptor and contributing towards the development of tolerance, which we discussed later. And further, beta-arrestin 2 also independently modulates cell signaling, and this may also contribute towards tolerance and other undesirable side effects of opioids, example, constipation and respiratory depression. So if you want to start a patient on per oral morphine, the dose is calculated to give a greater analgesic effect than the medication already in use. So if opioid naive, frail or elderly, start with a lower dose, that is 5 mg Q4 hourly. And if the patient was previously receiving a weak opioid regularly, give 10 mg Q4 hourly or modified release formulation of 20 to 30 mg Q12 hourly. Also add an antiemetic like haloperidol 500 microgram per roller on PRN use, and also add a laxative. So there are 3 schemes which we can start per oral tablets. The scheme 1 is to use immediate release morphine oral solution or tablets. The morphine is given Q4 hourly by the clock with PRN doses, which is 1/10 to 1/6 of the 24-hour dose. And after 1 to 2 days, we have to recalculate the Q4-hour dose by dividing the total used in previous 24 hours, that is regular plus PRN divided by 6, and continue the Q4-hour and PRN dose, and increase the regular dose until there is adequate relief throughout each 4-hour period with PRN, and double dose at bedtime can also be given. Scheme 2 is for immediate release morphine and modified release morphine. So we have to continue the scheme 1, and once stable Q4-hour dose is obtained, replace it with modified release morphine Q12 hourly. The Q12-hour dose will be 3 times the Q4-hour dose, and continue PRN as 1/10 and 1/6 of the 24-hour dose. Now scheme 3 is start with 20 to 30 mg Q12 early or 10 mg Q12 early in flail elderly, and use 1/10 to 1/6 PRN dose of immediate release morphine, and increase the dose of MR morphine every 2 to 3 days. So when per oral medications are not possible, like in difficult swallowing or in increased vomiting, so the subcutaneous route or continuous subcutaneous infusion can be given. In strong opioid naive patients, start with 20 mg per 24 hours continuous subcutaneous infusion and 5 mg subcutaneous PRN. Half both the doses in frail elderly or mild moderate renal impairment, and if necessary, titrate the dose upwards guided by PRN use. When switching morphine per orally to continuous subcutaneous infusion, divide the total per oral dose by 2 and retitrate as necessary, and dilute with 0.9% saline or 5% glucose. For IV and continuous IV infusion, it is used for rapid relief of severe pain caused by acute trauma and medical emergencies. And in opioid naive patients, give a prophylactic antiemetic IV, example metoclopramide 10 mg, if not contraindicated, and over 5 to 10 minutes, give a total of morphine 5 to 10 mg and 2.5 mg in elderly IV. When insufficient, give additional morphine at a rate not exceeding 1 to 2 mg per minute until satisfactory relief is obtained, and monitor for undesirable side effects like excessive sedation and respiratory depression. The dose can be repeated Q2 to 4 hourly as required. So the rapid IV subcutaneous titration of morphine dose for severe cancer pain have two methods, which are as follows. So this is by the Institute of Palliative Medicine, India. The prerequisites is pain should be more than 5/10 on a numerical scale. And there would be a probability of a partial or incomplete response to morphine, as most of the patients will already be taking an NSAID. And the method is to obtain a venous access with butterfly cannula, give metoclopramide 10 mg IV routine relief, no contraindications, and dilute the contents of 15 milligram morphine ampule in a 10 ml syringe. The ampule strength varies and can use the local standard. Here at TMH, we use 10 milligram per ml solution. So a bolus dose of 2 milligram is used. So inject 1.5 milligram, that is 1 ml every 10 minutes until the patient is pain-free or complains of undue sedation. If the patient experiences nausea, give additional metoclopramide 5 mg IV. So in 40% of patients, 1.5 to 4.5 mg of dose can produce relief. But in around 40%, 6 to 9 milligram is required. And in 15%, 10.5 to 15 milligram. And in 5%, more than 15 milligram is required. So complete relief is obtained in 80%, whereas in 1%, no relief is obtained. And the undesirable side effects, 32% can have sedation, while other side effects are seen in just 3%. So prescribe a dose of per-oral morphine, Q4 hourly, similar to the IV dose, rounded to the nearest 5 mg. Example, if needed morphine is 3 to 6 milligram IV, so there would be 5 mg per oral, and in the minimum dose is 5 mg. And advise about PRN doses, and if more required is more than 2 per 24 hours, so increase the dose the next day. And in practice, 20% of the patient need a dose increase within 3 days. And the other method is based on practice at Cleveland Clinic, where through IV 1 milligram per minute up to 10 mg is given, and there's a pause of 5 minutes. While it's for subcutaneous, 2 mg Q5 minutes up to 10 mg, where a pause of 10 minutes. So the cumulative effective dose is Q4 hourly equal to Q4 hourly dose. So example, if cumulative effective dose is of 9 mg, so giving intermittent injections dose of 9 mg Q4 hourly, that is rounded to 10 mg. And if continuous IV infusion, total daily IV dose equal to 9 mg multiplied by 6 times. So that is 54 milligram per 24 hours. So to round this up or down to convenient number of ampules, that would be 50 mg or 60 mg. So PRN doses would be around 5 to 10 mg Q1 hourly. But here the patients are maintained on continuous IV infusion for several days before conversion to per-oral medication. And here the naloxone should be readily available. And we can also use IV patient-controlled anesthesia, which is costly and require inpatient admission and may take more than 10 hours to achieve relief. And patient should be monitored closely, and the underlying cause may be transient. So therefore, a subsequent reduction in dose will be necessary. Now, morphine can also be used for breathlessness. The mechanism exact is unclear, but the following could be the mechanism, like diminishes the chemoreceptor response to hypercapnia and hypoxia, reduces pain-induced increased respiratory drive, decreases anxiety, causes cortical sedation, therefore reduced respiratory awareness, blunted efferent transmission from mechanoreceptors, reduces metabolic rate and ventilatory requirements, and causes vasodilation, hence improved cardiac functions. So relevant to performance status and prognosis of the patient, it can be used for shortness of breathlessness at rest, and in COPD, CHF, and cancer, which supports oral and parenteral use of morphine, according to systemic review and meta-analysis by Triphosphate et al. In 2016 and Boswin et al. In 2014. So for in opioid naive, for the IR approach, the first week 500 microgram per oral BD, which can be increased to 500 microgram QDS at 48-hour interval, and can be increased up to 1 milligram Q4 hourly. So at weekly interval, increase Q4 hourly dose to 2 mg, then to 3 mg, and then to 5 mg weekly. And if necessary, continue to adjust each week using 30 to 50% dose increments, and reduce dose if undesirable side effects occur. And if persistent, consider a switch to an alternative opioid. And when the dose is unchanged for 2 weeks, consider switching to modified release formulation. For modified release approach, 5 mg per oral BD for 1 week. And if baseline breathlessness not reduced more than 10%, then 10 milligram per 24 hour weekly can be given. And usual maximum dose is 30 milligram per 24 hours. And breathlessness in the last days of life in opioid nerve patients start at morphine 5 to 10 milligram per 24 hours with midazolam 10 milligram per 24 hours by continuous subcutaneous infusion. It can also be given as subcutaneously by morphine 2.5 mg and midazolam 2.5 mg subcut PRN Q1 hourly. And for those already receiving per oral morphine or another opioid, convert to the equivalent parenteral 24-hour and PRN doses and titrate both PRN and regular doses to obtain satisfactory relief. And we can also add haloperidol or levopromazine if the patient develops an agitated delirium. There are 3 receptors. So mu-opioid receptors, which is present in the brainstems and medial thalamus. It is present in brainstem and medial thalamus, and its function is supraspinal and spinal analgesia, sedation, inhibition of respiration, slowed gastrointestinal transit, modulation of hormone and neurotransmitter release. The kappa receptor, which is found in limbic and diencephalon brainstem and spinal cord, it causes supraspinal and spinal analgesia, modulation of hormone and neurotransmitter release. And the delta, which is present in diffusely brain and function is supraspinal and spinal analgesia, psychomimetic effects and slowed GI transit. So the undesirable side effects are gastric stasis, sedation, cognitive failure, myoclonus, neurotoxicity, vestibular stimulation, pruritus, and histamine. For gastric stasis, the symptoms would be epigastric fullness, flatulence, persistent nausea. So we can add a metoclopramide of around 10 mg per oral or subcutaneous TDS. For sedation, there would be intolerable persistent sedation. So we have to reduce the dose of morphine and add psychostimulant like methylphenidate 5 mg per oral BD. For cognitive failure, there would be agitated delirium with hallucinations. So add an antipsychotic like haloperidol, 500 microgram per oral subcut stat with Q2R PRN. And for myoclonus, there would be multifocal twitching and with jerking of limbs. So we had to add a benzodiazepine diazepam per oral or midazolam subcut 5 milligram stat and Q1R PRN. For neurotoxicity, there would be abdominal muscle spasm, symmetrical jerking of legs, whole body allodynia, and hyperalgesia. So we had to add a benzodiazepine, diazepam, or midazolam. And for vestibular stimulation, there would be movement-induced nausea and vomiting. So we have to add an antihistaminic, antimuscarinic, antiemetic. Example, cyclizine 50 milligram per oral or subcut TDS. For pruritus, we can add an antihistamine. And if there is histamine release with bronchoconstriction causing breathlessness, we can treat it as for anaphylaxis. The organ system effects of morphine are 2, like central nervous system effects and peripheral nervous system effects. So central nervous system effects include analgesia, euphoria, sedation, and respiratory depression. For analgesia, the pain consists of both sensory and affective, emotional components. So opioid analgesics are unique in that way they can reduce both the aspects of the pain experience, in contrast to the NSAIDs, which have no significant effect on the emotional aspect of the pain. It causes euphoria. Typically, patients of intravenous drug users or patients who receive intravenous morphine experience a pleasant floating sensation with less than anxiety and distress. However, dysphoria, an unpleasant state characterized by restlessness and malaise, may also occur. And it causes drowsiness and clouding of mentation. And there is a little or no amnesia. Sleep is induced by opiates more frequently in the elderly than in young and healthy individuals. And ordinarily, the patient can be easily aroused from the sleep. However, the combination of morphine with other central depressant drugs such as the sedative hypnotics may result in very deep sleep. So marked sedation occurs more frequently with compounds closely related to the phenanthrene derivatives and less frequently with the synthetic agents such as mepridine and fentanyl. And in standard analgesic doses, morphine disrupts normal REM and non-REM sleep patterns. This disrupting effect is probably characteristics of all opioids. And it can also produce significant respiratory depression by inhibiting the brainstem respiration mechanism. Alveolar PCO2 may increase, but the most reliable indicator of this depression is a depressed response to a carbon dioxide challenge. And the respiratory depression is dose-related, and when strongly painful stimuli that have prevented the depressant action of a large dose of an opioid are relieved, respiratory depression may become marked. And opioid-induced respiratory depression remains one of the most difficult clinical challenges in the treatment of severe pain. And ongoing research to overcome this problem is focused on mu receptor pharmacology and serotonin signaling pathways in the brainstem respiratory control centers. And it also causes meiosis. This constriction of pupils is seen with virtually all opioid agonists. Meiosis is a pharmacological action to which little or no tolerance develops, even in highly tolerant addicts. Thus, it is valuable in the diagnosis of opioid overdose. This action, which can be blocked by opioid antagonists, is mediated by parasympathetic pathways, which in turn can be blocked by atropine. It also causes nausea and vomiting. It activates the brainstem chemoreceptor trigger zone to produce nausea and vomiting. As ambulation seems to increase the incidence of nausea and vomiting, there may also be a vestibular component in this effect. And homeostatic regulation of body is mediated in part by the action of endogenous opioid peptides in the brain. For example, administration of mu-opioid receptor agonists such as morphine to the anterior hypothalamus produces hyperthermia, whereas administration of K agonist induces hypothermia. And although the mechanism by which opioids interacts with circadian rhythm is unclear, they can decrease the percentage of stage 3 and 4 sleeps, which may result in fatigue and other sleep disorders, including sleep disordered breathing and central sleep apnea. Coming to the peripheral effects, so seen in cardiovascular system, it has no significant direct effects on the heart, and other than bradycardia, no major effects on cardiac rhythm. And blood pressure is usually well maintained in subject receiving opioids unless the cardiovascular system is stressed, in which case hypertension may occur. This hypertensive effect is probably due to peripheral arterial and venous dilation, which has been attributed to a number of mechanisms, including central depression of vasomotor stabilizing mechanisms and release of histamine. So no consistent effect on cardiac output is seen, and the electrocardiogram is not significantly affected. However, caution should be exercised in patients with decreased blood volume because the above mechanism make this patient susceptible to hypertension. Constipation, which has long been recognized as an effect of opioids, an effect that does not diminish with continuous, and tolerance does not develop to opioid-induced constipation. And the opioid receptor exists in high density in the GI tract, and the constipating effects of the opioids are mediated through an action on the enteric nervous system as well as the CNS. So in the stomach, motility, that is rhythmic contraction and relaxation, may decrease, but the tone may increase, particularly in the central portion, and gastric secretion of hydrochloric acid is also decreased. In small intestine, resting tone is increased with periodic spasm, but the amplitude of non-propulsive contraction is markedly decreased. And in large intestine, the propulsive peristaltic waves are diminished, the tone is increased. This delays the passage of the fecal mass and allows increased absorption of water, which leads to constipation. It contracts biliary smooth muscle, which can result in biliary colic. The sphincter of Oddi may constrict, resulting in reflux of biliary and pancreatic secretions and elevated plasma amylase and lipase levels. And the renal function is also depressed by morphine. This is chiefly due to decreased renal plasma flow. So in addition, mu-opioids have an antidiuretic effects in humans. So mechanism may involve both the CNS and the peripheral sites. It also enhances renal tubular sodium reabsorption. So uretral and bladder tones are increased by therapeutic doses of the opioid analgesics. And it increases the sphincter tone, which may precipitate urinary retention, especially in post-operative patients. And occasionally uretral colic caused by renal calculuses is made worse by opioid-induced increase in uretral tone. In uterus, the opioid agents may prolong labor. Although the mechanism of this action is unclear, both mu and kappa opioid receptors are expressed in human uterine muscles. Fentanyl, mepridine inhibit uterine contractility, but only at supraclinical concentration. Morphine had no reported effects. In endocrine, it stimulates the release of ADH, prolactin, and somatotropin, but inhibit the release of luteinizing hormone. These effects suggest that endogenous opioid peptides, through effects in the hypothalamus, modulate these systems. And patients receiving chronic opioid therapy can have low testosterone, resulting in decreased libido, energy, and mood. And women can experience dysmenorrhea or amenorrhea. It also produces flushing and warming of the skin, accompanied sometimes by sweating, urticaria, and itching. Although peripheral histamine release is an important contributor, all opioids can cause pruritus via central action on proprioceptive neural circuits. And when opioids are administered through the neuroaxis by the spinal or epidural route, their usefulness may be limited by intense pruritus over the lips or torso. And morphine also modulates the immune system by effects on lymphocyte proliferation, antibody production, angiogenesis, and chemotaxis. In addition, leukocyte migration to the site of tissue injury and release opioid peptides, which in turn help counter inflammatory pain. However, natural killer cell cytolytic activity and lymphocyte proliferative responses to the mitogens are usually inhibited by opioids, which may play a role in tumor progression. Although the mechanism involved are complex, activation of central opioid receptors could mediate a significant component of the changes observed in peripheral immune function. These effects are mediated by the sympathetic nervous system in case of acute administration and by the hypothalamic pituitary adrenal system in case of prolonged administration of opioids. Now, the various caution has to be observed, that is renal impairment and severe hepatic impairment. In renal impairment, half-life of MCGX increases from 2.5 to 7.5 hours and gets accumulated, so can be used with caution. So in create clearance of 30 to 60 ml per minute, 75% of the normal dose should be used. And in create clearance of 10 to 30, 50% of the dose should be used. And in create clearance of less than 10 or patient on hemodialysis, 25% of the normal dose should be used. So for mild to moderate renal impairment, 5 mg Q8 hourly or Q6 hourly is used. And in severe renal impairment, to start with 1.25 or 2.5 mg PRN and shift to equivalent dose of fentanyl transdermal patch. And well tolerated in patients with mild to moderate hepatic impairment, but there is prolonged prothrombotic time and plasma half-life increases. To understand the various drug interactions, the drug undergoing phase 2 metabolism have little potential for metabolic-based pharmacokinetic drug interactions, and pharmacodynamic drug-drug interactions are possible with all opioids such as additive interactions with benzodiazepines, antihistamines, or alcohol, and antagonist interactions with naltrexone or naloxone. But the following has been reported with oral morphine, also their clinical relevance is unknown. Like rifampicin, which may reduce plasma levels of morphine, possibly via the induction of P-glycoprotein in the GI tract, and quinidine, which may increase plasma levels of morphine via the inhibition of P-glycoprotein in the GI tract, and may also increase levels of gabapentin by slowing GI transit time. And metoclopramide may increase the rate of absorption of morphine via increased gastric emptying. So mechanism involved in morphine addiction is morphine and opioid drugs induce strong analgesia, euphoria, sedation, endocrine dysregulation, meiosis, antitussive activity, or respiratory depression. Additionally, induce muscle spasm and histamine release in the peripheral nervous system. So chronic exposure to morphine induces the phosphorylation of opioid receptors for arresting binding. This opioid reward effects, which is associated with stimulation of structures within the mesolimbic system, such as the ventral tegmental area and nucleus accumbens, increase in dopamine release in the nucleus determines the feeling of pleasure. So this dysregulation of rewarding dopamine pathway in the brain is responsible for the addiction, associated with stimulation of mu receptor localized in the GABAergic terminals of the ventral tegmental area, which inhibits the GABA release, which in turn disseminates the dopaminergic neurons. And this release of dopamine in the nucleus accumbens induces feeling of euphoria and promotes development of drug dependence. Morphine. So chronic morphine abuses leads to physical and psychological dependence. So chronic dependence is a characteristic withdrawal symptom that can develop after abrupt cessation of drug administration and includes sneezing, runny nose, cough, abdominal pain, diarrhea, anorexia, and anxiety. And the second parameter is morphine tolerance, which develops regarding analgesic, euphoric, sedative, respiratory depression, and nauseating effects of opioids, but not to their effects on meiosis and bowel motility. The pharmacokinetic tolerance refers to changes in distribution or metabolism of the drug, and learned tolerance refers to reduction in the effects due to compensatory mechanisms that are learned, such as behaving normally while still intoxicated. These are neuroadaptive changes that take place after long-term exposure to the drug, including changes in the receptor density and alteration in receptor coupling to G protein and signal transduction pathways. The expression of morphine sensitization is associated with an increased dopamine release, as we have seen, and with alteration in the sensitivity of dopaminergic D1 receptors in the mesolimbic structures, including the striatum, nucleus accumbens, and hippocampus and prefrontal cortex. So due to persistent activation of mu receptors, such as in severe chronic pain, there is receptor recycling, that is failure to induce endocytosis of the mu receptors. Methadone, a mu receptor agonist, is used for the treatment of opioid tolerance and dependence, which induces receptor endocytosis. This suggests that maintenance of normal sensitivity of mu receptor requires reactivation by endocytosis and recycling. and also receptor uncoupling due to dysfunctional of structural interactions between the mu receptor and G protein, second messenger systems, and their target ion channels. Example, ketamine, which is an NMDA receptor antagonist. So the epigenetic mechanisms of morphine tolerance and dependencies, the chronic exposure induces complex epigenetic interactions within a genome, thereby regulating patterns of gene expression. It includes changes in DNA methylation, histone acetylation, and demethylation. So alterations in DNA accessibility and chromatin structure modification. The first role of DNA methylation and histone acetylation in mu-opioid receptors expression was published in 2007. And chromatin modification also participates in the mu-opioid gene expression. And there is also a role of histone methylation in the effects of chronic morphine exposures. So with populations like morphine, the clearance may be reduced in older patients, and Chinese patients have higher clearance of morphine, whereas for hepatic impairment and renal impairment, dose adjustments is recommended, which has been discussed earlier. So I'll also be discussing regarding the pharmacogenomics. So despite standard treatment for pain, 10 to 30% of patients are not able to reach their pain management goals due to either inadequate analgesia or untoward side effects. So among the many causes, the inter-individual differences attributes to genetic variations. So around 12 to 30% of the response variation is attributable to genetic variations. So morphine encounters several proteins in the body, including UGT2B7, OPRM1, OCT1, COMT, and P-glycoprotein. So I will be discussing some of the more frequent studied genetic polymorphism impacting these proteins and their associated functions characteristics. So first is an opioid receptor, mu1. It encodes the MOR, morphine opioid receptor, which belongs to the G protein coupled receptor, superfamily of transmembrane proteins, transmembrane receptors. And it is the primary set for endogenous and exogenous opioid-mediated pharmacological responses. It mediates analgesia, tolerance, and reward effects of opioids. So OPRM1 118 G by G homozygotes requires a higher dose of morphine compared to patients with the wild type OPRM1 18A by A zygotes. And Kampa et al. Study revealed that OPRM1 18A homozygotes were associated with significantly higher decrease in pain compared to the GG homozygotes. So OPRM1 18G allele were the poorest morphine responders, and that OPRM1 18AA were good responders to morphine. And the next would be catechol-O-methyl transferase. So Reyes, Gibby et al. In 2007 found COMT RS4680, Val-Val, and Val-Met required higher methyl equivalent drug dose compared to Met genotypes. And Rakwag et al. In 2008 found that patients with carriers of A alleles of COMT, that's RS4818 and RS4680, were associated with lower morphine equivalent drug dose requirements. And Oliveira et al. In 2012 found that COMT RS4680 Val-Met as short nucleotide peptides was associated with higher morphine equivalent drug dose requirements. Now coming to UGT2B7 gene polymorphism, it was the most frequently studied UGT2B7 gene polymorphisms are UGT2B7 802T-C and UGT2B7 99G-A. And Messner, KM et al. In 2011 suggested that carriers of 802 allele experienced a higher peak and extended analgesia compared to subjects homozygous for the 802C allele, indicating that 802 allele may result in reduced glucuronidation activity. Now coming to organic cation transporter isoform 1. It is an influx transporter encoded by the solute carrier family 22 member 1 gene. And morphine is a high affinity substrate for OCTT1. So according to the 35 ZCOV MF in 2013, carriers of the loss of function of OCT1 polymorphism had significantly higher plasma concentrations compared to the non-carriers. So among children, morphine clearance was significantly lower in homozygote carriers of loss of function of OCT1 variants. Coming to adenosine triphosphate binding cassette subfamily B member 1, it impacts pharmacokinetics of morphine regarding drug absorption from the intestines and first pass metabolism by the liver. The RS104564 variant corresponds to the ABCV1C3 3435T polymorphism. And the study by Kampadi et al. In 2014 showed that RS1045642 strongly and independently affects morphine responsiveness, and that patient homozygous for the ABCB1 3435T allele from the and the OPRM1 18A allele were the best responders to morphine. The other genes of interest are ARRB2 protein, involved with agonist-mediated desensitization of G protein-coupled receptors and cause specific dampening of cellular responses to stimuli, such as the opioid agonist activity of morphine on the morphine-opioid receptors, but no significant findings were there in any studies. So in short, the cancer pain severity was negatively associated with intron variant alleles in OPRN1 RS932246, RS2270459, RS625210. In opioid daily dose was positively associated with intron variant alleles in COMT RS9306234, RS165728, RS2020917, and RS165728, and ARRB2 RS1045280. An improvement in pain with opioids in patients receiving supportive care was negatively associated with OPRN1 RS1319339 and RS3442787 and COMT RS4646316, RS35478083, and interleukin-6 gene. Now I'll be discussing the morphine and the immune function. Opioids modulate immune cell functions directly by binding to the opioid and toll-like receptors on immune cells, and indirectly via activations of the hypothalamic pituitary adrenal axis and the sympathetic nervous system. So immune function is suppressed by the immune-induced release of glucocorticoids and catecholamines, example adrenaline, noradrenaline, from the adrenal medulla, and the release of catecholamines and neuropeptide Y from the sympathetic nerve fibers, which innervate the lymphoid tissue, example lymph nodes and spleen. Thus, in some studies, morphine depresses natural killer cell activity, T lymphocyte proliferation, monocyte macrophage functions, and cytokine release, example interleukin IL-2 or interferon 1, potentially reducing the host resistance to bacteria, fungal, and viral infections, and impending cancer immunosurveillance. Morphine can also influence cancer cells, as it is the mechanism is unclear. In the overall effect is beneficial or deleterious. Cancer cells also express opioid receptors, further complicating this area of research. So in animal models of cancer, their overexpression is associated with cancer growth and metastasis, with contrasting reports of exogenous opioids either stimulating or inhibiting the angiogenesis. So pain is immunosuppressive. Opioid analgesia may improve immune function in patients with pain. However, overall data are limited and inconsistent, and the clinical implication of these effects are uncertain. Nonetheless, they may help to explain the increased susceptibility to infection seen in opioid abusers. On the other hand, because pain is immunosuppressive, opioid in analgesia may improve immune function in patients. So morphine in non-cancer pain, the major conclusion is that from the Mollin DE et al. Study in 2020 is that that 9 weeks of oral morphine in doses up to 120 milligram daily may be of analgesic benefit, but is unlikely to confer psychological or functional improvement. And the carryover effect of reduction of pain intensity is difficult to explain, but probably represents persistence of a psychological effect into the second treatment period, since the 2-week washout phase and short half-life of morphine, about 3 hours, preclude a pharmacological explanation. Whereas the 3 systematic reviews evaluating the long-term effectiveness of opioids for chronic non-cancer pain provided unclear and weak evidence. The result of this review showed that many patients in the included studies were dissatisfied with adverse events or insufficient pain relief from opioids and withdrew from the studies. And for patients who were able to continue on opioids, evidence was weak, suggesting that their pain scores were lower than before therapy and that this relief could be maintained long-term for more than 6 months. There was also weak evidence that long-term opioid therapy with morphine and transdermal fentanyl not only decreases pain, but also improves functioning. So limited evidence was available for the most commonly used opioids, oxycodone and hydrocodone. And evidence for the ability to drive on chronic opioid therapy was moderate without major side effects or complications. So it was concluded that for long-term opioid therapy for 6 months or longer in managing chronic non-cancer pain with improvement in function and reduction in pain, there is weak evidence for morphine. And just as a side point, that simple substitution of an allyl group on the nitrogen of the full agonist morphine plus addition of a single hydroxyl group results in naloxone, a strong mu-opposite antagonist. So I would like to end my seminar with the note that chemistry makes a large difference. Thank you.
Thank you, Prajakta, for that wonderful and in-depth presentation on morphine. So before taking up the question, may I open this session for expert comments?
So Prasun, we can ask comments, and because we have now, I can see that a lot of senior people have joined the seminar. So maybe we can ask their take-home message about morphine. Like
Yeah, sure, ma'am.
We can start with Dr. Jennifer. Dr. Jennifer. Dr. Nandini, then Dr. Stanley, Dr. Seema. Yes, Dr. Stanley. Yes, please.
Just to emphasize, in the context of overdose, a very important clinical sign is pinpoint pupils. It's not just meiosis that you keep in mind. Once you see pinpoint pupils, you will not forget it. So I would like to emphasize that, and it's such a simple way of realizing that the sedation or whatever it is due to overdose. So I would stress that.
Thank you, Dr. Stanley. Archana, see, Dr. Jennifer is unable to unmute, please.
Yeah, yes, ma'am. I'm able to unmute now.
Go ahead.
Yeah. Thank you for that excellent presentation. I think morphine is a great boon for severe cancer pain, especially wherever it is available. And as we've been listening to these lectures, we realize even in moderate pain, like low doses of morphine are much better than trying tramadol or other weak opioids. So the role of morphine in cancer pain is quite large and broad. One thing we need to be careful is in how we initiate and titrate. And I think where we should be very careful is if somebody comes with pain which is not responding, or a patient is still having pain despite being on adequate doses of morphine, is to evaluate what is the cause for unresponding pain, to go through the drug history. Is a patient compliant? Is this an opioid responsive pain? Is there something else that has newly happened that has caused an increase in severity of pain? We should not quickly jump to keep increasing
Yeah, you are again muted, Dr. Jennifer. Yeah, go ahead.
Okay, sorry, I'm not sure where I missed. I just wanted to emphasize the fact when patients come with unresponding pain, instead of quickly going on increasing opioid doses, it's very important to understand why pain is not responding, the compliance, the need use of PRNs, any new event that has happened which has caused an increase in pain, and then to titrate. And like Dr. Stanley mentioned, to look for signs of overdose, myoclonus or meiosis. Yeah, thank you.
Thank you, Dr. Jennifer. Maybe Dr. Shobha, Dr. Seema Mishra, Dr. Nandini. Shobha?
Yeah, hi Sushma.
Yeah,
Can
Nandini, yes, Nandini, go ahead.
Yeah, so excellent presentation, very detailed, and I learned so much more about the practical aspects. I re-emphasize regarding selecting the right patient with the right pain. Otherwise, just severity alone may not be enough. We may be missing a fracture, which is causing the escalation and non-responsiveness. There may be an infection. So we need to keep looking out for new reasons. So the review part cannot be overemphasized. Second thing, I saw the table that Doctor shared regarding the different toxicities, and so she had listed all the events and the treatment part. Like for example, myoclonic jerks. There was a mention of giving benzodiazepines, and I would say that the reducing the morphine dose goes through across that table. We need to de-escalate the dose of morphine because that is the primary cause of it. So on top of a overdose morphine, because it may be that somebody follows that table literally, then if an additional benzodiazepine is given, we are going to increase the chances of adverse effects even more. So the importance of reducing the dose right through all the signs of overdose cannot be overemphasized. Yeah, and I love the last comment about chemistry being so important in effects. Thank you.
Thank you, Nandini. Thank you very much. Shobha, Seema.
Good morning, Sushma. This is Shobha here. Good morning, everyone. I would agree with Jennifer when she said that of late, I think we have all been starting to use morphine for moderate pain. So even when when we feel that, okay, tramadol would be sufficient or tapentadol would be sufficient for this patient, even if we start that and there's not much, there is response, but it's not adequate. And so we start with, in my personal experience, we've started with maybe even 3 times a day dose of morphine, half a tablet. And I've seen dramatic responses. Just a couple of weeks ago, I've done that with 2 of our patients, and there's been a tremendous improvement in their pain, not even giving 4-tali morphine. So that's a personal experience. There's no evidence for it, but it's just an observation that we had. And the other thing that I want to emphasize is many a times, of course, in palliative medicine, there is polypharmacy, as we know. And I always wish we could, make all these into one tablet, prescribe, and then put it in a machine, and then just give this one tablet to patients, which is not possible at all. So I think we always overlook what are the medications that we give along with morphine. For example, a lot of patients will have fluconazole, which is an inhibitor of enzymes. So morphine, as we heard, there are a lot of liver enzymes which helps with its metabolism, and not only CYP3, but COMT and those kind of things. So fluconazole, so you have to keep in mind whether it is an inhibitor, so the dose more, or looking at other things, whether the effect is less. So maybe because of that, but we have to still give those medications, and we have to keep in mind. So whenever we give it, it's better to probably look up, and we can't remember this all the time, like which is an inhibitor and which is a stimulator. So that's why we have SIMS or BNF or those kind of books, so we can always look it up and have evidence-based practice or pharmacological-based practice. Sometimes these things are like theory. Sometimes we don't see this very much clinically, but it's always better to keep our ears and eyes open and to look for it. Unless and until we look for it, we won't be able to find it. So thank you.
Thank you, Shobha. Thank you very much. I think I can see so many senior people. Yes, please.
Sushma, can I just make just one more comment?
Yeah, Nandini, yes, quick comment.
Nandini here. Yeah, so this is regarding, some of the tables that come from studies abroad. We need to remember that their nutritional status, the Caucasian, the racial structures, and the lifestyle, sometimes they are on regular use of, daily, they consume alcohol, etc. So we cannot copy the exact table for our patients who are much lower in, nutritional status, and the body distribution, lean body mass will be different. The muscle amount will be different. So always, deduct give a discounted dose. Don't follow the dosages which are mentioned. Like there was one just showing as Cleveland Clinic's recommendation for rapid titration. That may be a bit too much for our Indian patients. Thank you.
Thank you, Nandini. Seema, if you are there, then Dr. Reena and Dr. Joyita, quick comments, your experience, and I can see Vidya also. But we have limited time now. We want to take all four comments from all four of them. So one by one. So Seema, are you there? Seema Mishra. Otherwise, Dr. Reena George.
Just a couple of things. One is that one common acute cause of non-responsive pain is necrosis within the tumor. So that inflammation may not respond, and you might see opioid toxicity in somebody who was earlier responding to morphine. Head and neck patients example, that's common. Second, if you're seeing a fair bit of vomiting in your patients, consider giving an antiemetic regularly for the first 2-3 days, because patients can lose trust in a drug if they vomit. That depends on what the situation is in your population. Thirdly, if you find that someone has remained stable and on morphine for years, just recheck whether there is actually a cancer recurrence or whether it is some fibrosis or something, in which case you can titrate down and use adjuvants and treat it as a chronic pain rather than a palliative cancer pain.
Thank you, Dr. Reena. Thank you very much. Seema, are you there?
Yes, ma'am.
Okay, Seema, go ahead.
Yeah, I think first of all, it's very comprehensive presentation by Prajakta. And one more thing, that she has comprehensively taken care of the genomic part, and that before going for thinking about the genomics, I just want to highlight that we have to do the comprehensive assessment why the patients are not responding, that instead of directly jumping over that there can be a genomic things in our country. So that is only one point I have really highlight. And I'm very that Dr. Snelle has commented about pinpoint people. I think once we see the pinpoint people, we can never forget in the clinical practice that overdose, how to really diagnose the overdose of morphine. That's all.
Thank you, Seema. Joyita?
And thank you, ma'am. Excellent presentation, Prajakta. I think it's important to take the question. So
Okay.
Because we have only 3 minutes left. Thank you.
Thank you, experts, for your valuable comments. Like now taking the questions very quickly, anyone having experience of using methylphenidate? So methylphenidate, usually as she described, it's for intolerable sedation, which we have actually not come across because we reduce the dose. And yes, we do have experience of using modafinil for the same matter. And we have got excellent results because modafinil is relatively easily available and better tolerated. So instead of methylphenidate, we have used modafinil and we have got good results. Second, from Neetu Susan, does sphincter of Oddi dysfunction pose any contraindication to the use of morphine in pediatric patients with GI malignancies? So Neetu, not just for pediatric patients, for adult patients also. If you are suspecting that the abdominal pain is because of colic, if it's a biliary colic and the disease is somewhere related to HPV, that is hepatobiliary pancreatic cancers or something, and if you are suspecting that the pain is biliary colic type, then definitely do not go for opioids. And in that matter, buprenorphine is a better choice, which does not cause the increased spasm of sphincter of Oddi, and so is fentanyl. So in cases where you suspect a spasm of sphincter of Oddi to be the cause of pain, better to avoid morphine and go for other opioids like buprenorphine or fentanyl, which costs relatively less. And as a comment to Dr. Nandini ma'am's comment about the use of Cleveland Clinic thing. So what we usually follow in Tata is the Cleveland thing of Ohio, where we give 1 milligram morphine every minute and titrate, and that hasn't, like, yeah, definitely for Indian population, we need to reduce the dose because the height, weight, and the nutritional status is very much different from what we see in the West. So we can't extrapolate all the data to that, but we have been pretty successful in using the Ohio thing, that is titrating every minute. So the Indian thing, what we find is like we have to titrate every 10 minutes. The Indian scenario, like the 1.5 milligram every 10 minutes. So if a patient requires like 4.5 milligram of morphine for his pain control, it will take half an hour in a crisis situation. So that is something which we do not want for our patients. So the Ohio method covers that in maybe like 5 minutes or so. And we have been pretty successful in doing that without any adverse effects so far.
Thank you, Prasun. Thank you, Dr. Bhagat Prajakta. And thank you, Joyita. Thank you all senior faculty members. And it's so encouraging to see. I think Vidya's comments we have left, but there are many senior people, those we just cannot now say at 7:30. So one last thing I want to say that using morphine is an art. We will keep on getting new experience with every patient. So every patient is going to be different as far as morphine users are concerned. One thing is common, that morphine is a good pain reliever. And in 60 to 70% of patients, it is going to give pain relief. But you have to have a habit of monitoring all sorts of side effects, which Dr. Bhagat has explained so beautifully well. And we all know that it is required. And you need to have a good set of art, how to use it and how to follow it and how to monitor it. And once you will start using all these three combination will be there, your patient will be, you will be a person who will be using morphine very, very judiciously. So all those who are listening, go and read it more so that you will get all this lecture will be there on the website. If you want to see the slides, you can see the slides. If you want to read, you can read, but it is an art and it will need a lot of expertise. And with every passing patient, you will have a lot of confidence of using morphine, because I have seen a good, extraordinary interventional pain physician. They told me that we don't know how to use morphine. So if you really want to become an excellent pain physician, you have to have a good knowledge of morphine, which Dr. Bhagat has explained, and you have to have a good experience of using morphine, because with every patient you will use, you will learn more. So thank you very much. See you everyone next week, Monday before 6:30. And thank you, Joyita, Prasun, Dr. Bhagat, and Archana and Nisha. And thank you everyone for joining. And thank you all the faculty members, those who have contributed. Thanks a lot.